Hello, everybody. Welcome back to the Incubator booth at NeoHeart 2024. We are so fortunate to be joined by Dr. Aditya Kaza, aka AK.
Correct.
Aditya, thank you so much for taking the time to drop by the Incubator booth today.
No, my pleasure. I think this is the second year that I've attended this meeting, and I'm surprised with how many different specialists this meeting is able to bring together.
For sure.
I think my ultimate selfish goal is how can we parlay this into improving the outcomes for our neonates with congenital heart disease. And this has been a great meeting thus far.
And so I didn't really get the chance to introduce you formally, but you're coming from Boston Children, and tell us a little bit what you do at Boston Children.
I'm a pediatric cardiac surgeon at Boston Children's Hospital. I direct the neonatal cardiac surgery program. I do the full spectrum of surgeries from neonates to adults, but mostly trying to focus on improving outcomes for neonates. And how can we bring the different specialists together, break down the silos so we can deliver the best possible care we can for our patients.
And so you were part of a session this morning called Double Jeopardy, Prematurity and Congenital Heart Disease. I think there were a lot of interesting conversation about risk assessment, tracking outcomes. Can you tell us a little bit what are some of the takeaways you're taking home with you from this session?
The bottom line is there's no perfect tool to assess risk for the premature IUGR babies. The existing databases such as the STS, which is disease lesion specific, and the PC4, they don't capture the entire risk profile of these small premature babies. So one of the talks I was fascinated by was from a physician at UCSF, Dr. Stoyer, who's setting up a new type of database that takes into account all the maternal-fetal risk factors and the perinatal risk factors and incorporate them into a risk-adjusted model so we are better able to prognosticate how these newborns are going to do with any type of intervention. There was a great talk about how there's socioeconomic disparities in outcomes. And finally, Dr. Barsha talked about, the challenge I face every day, which is you have a premature baby with a cardiac lesion. When is the right time to fix this? Because the old adage was they're better off with a completely corrected circulation, but then there's the additive risks of prematurity and the other organ systems, and the risk to the other organ systems with cardiopulmonary bypass. So it was provocative talk, but I think it's the bottom line is that you have to tailor it to the individual patient and their individual risk factors about when to time the surgery.
Yeah, that's something that on the podcast Sunday, Gil Vernovsky and Nim Goldstrom and Amir Ashrafi were talking about, really this shift really in our field about what we think is the right approach surgically for these infants, about maybe fix the heart completely as early as possible, and that now really there's this shift where we say maybe not, maybe a staged approach is better. Can you tell us, since you are an expert, can you tell us a little bit about when that happened and where we are in this transition?
I think our neonates are primed for innovation. I think there's a lot of new technology that's developed and being used where we're able to provide less invasive stabilization of circulation in the cath lab. Previously, we underestimated the stress of a big operation on these neonates. Now, if you're able to do some sort of palliation in the cath lab and then get them to a state where they're more robust to be able to tolerate surgery, that's a win for everybody. So now when kids with truncuses who are premature, if you're able to put flow restrictors to protect their lungs and let them grow normally, then you can do the full repair when they're a little more robust. So I think this is a very exciting time in this field.
That's really interesting.
And then I was really intrigued. Like you said, we're having difficulty with the risk assessment, totally prognosticating. Do you think it's because the population is so diverse, or have we not picked the right measures to do? We haven't put our finger on what are the factors that really predict success in outcomes.
I think it's all of the above. I think STS is diagnosis specific. That's how we came up with our risk prediction model. But as you know, you guys being in this field full time, these premature neonates come in different varieties, different gestational ages, different birth weights, different morbidities when they're born, be it the bleed in the brain or bad lungs or etc. So I think the impetus is on us to develop a new risk-adjusted model for these newborns. So I think of this as an opportunity that we can innovate and develop something that'll help us have more educated discussions with the parents, with the families, prior to embarking on these sometimes complex and long journeys.
Even though there's significant regionalization of care for these infants with complex cardiac lesions, there's never enough for statistical purposes. I think if you're a statistician, you always wish there were bigger pool. Can you tell us a little bit about how beneficial it is for you as a surgeon, as an investigator, to come to a place like NeoHeart where you can actually network and engage with other big centers where maybe have visions for larger data sets and so on?
I think this is how great ideas start, right? That's why I said at the outset, this meeting is great because it brings people out of their little silos and you cross-pollinate, and then suddenly an idea like this starts in nascent stages where it's like, I think this is a great time. Maybe we can set up a meeting where at a meeting like this, all the stakeholders can meet and work and develop a database like this. No, I think all great ideas start at these meetings, and I think for our neonates with congenital heart disease, I think this is where the field is going to evolve. It's something like the NeoHeart where we're able to bring the experts together, pool their data, and develop this model.
I love that. And you also gave a lecture yesterday as part of the PDA stents breakout session. When PDA stenting is not an option, what is in the surgeon's toolbox? So what are the take-home points? What's in the toolbox?
Well, the gold standard, which is a shunt, which I don't know if the audience knows, is one of the highest risk procedures we do in the STS database. That's why we've looked for alternate pathways such as ductal stenting to provide pulmonary blood flow. So obviously, if the catheteers don't deem that that's feasible, then we revert back to the original standard, which is doing a surgical shunt, which is something I do from a sternotomy. It's a BTT shunt, the modified Blalock-Taussig Thomas shunt. We use Gore-Tex. We also have newer material called the Pica graft, which is expandable PTFE. So as the baby grows, they can dilate and accrue more growth. In Boston, we've also used cryopreserved veins from the tissue bank, femoral and saphenous veins, as a shunt material because they're less thrombogenic. One of the biggest risks with surgical shunts is thrombosis. So we've also invested quite a bit of intellectual manpower in trying to anticoagulate these babies, which presents its own set of risk factors. But the bottom line is, if they're not able to do it, we're able to do a surgical shunt, but it does impose a significant inflammatory response on the babies. I've seen it in the ICU. I had two babies in adjacent rooms. One had a PDA stent and another baby that had done a surgical shunt. It's night and day. I mean, the inflammatory response is much more pronounced in the patient that has to go to the operating room and get the surgical shunt, but we're able to do this if they're unable to implant a stent.
And so you're talking, I mean, that was such an innovative concept of cryopreserved vessels. Can you tell us a little bit how that works? I'm not familiar with that.
Yeah, I mean, it's our homograph bank. As you know, most of the conduits are cryopreserved pulmonary or aortic roots from other organ donors. So, but we also have saphenous and femoral veins from organ donors that I use for a lot of things. I use it to construct sonor shunts in my hypoplas because the femoral vein has a valve and prevents volume loading the RV. And as you know, biological material is less thrombogenic than anything artificial or prosthetic, such as PTFE. So that's really been helpful, and especially if somebody has a known coagulation defect, protein CS deficiency, I think you're better off using those.
Aditya, thank you so much for taking the time to share all this incredible knowledge with us. And we wish you a good rest of the conference and safe travels back to Boston.
My pleasure. Thank you,
you.
guys.